my name is Sarah Starpoli and I'm a physical therapy grad student at a local burn center in Portland, Oregon. Today I'm going to show you how to put on a hand splint and a foot splint. First up, hand splints. Here is a commonly seen hand splint used for burned hands. Hand splints are indicated for burns to the hand, edema control, joint protection, lack of active range of motion by the patient, and risk of contracture. The goal is the best possible outcome for the patient's hand. The position of splinting is wrist 30 degrees of extension, MCP 80 to 90 degrees of flexion, and full finger extension to protect muscle length, tendons, and the extensor hoods of the hand. Precautions are patients with sensation problems, improper donning, and exposed joints secondary to deep burns, which may need additional support, and you should refer to your therapy team if so. Here is a picture of a burned hand that would likely need a hand splint. Before we begin, the fit of the splint should allow patients' fingers to have proper MCP flexion and IP extension, secondary to the superb OT fabrication. So be in communication with your nurse or therapy team about any abnormal coloring or pressure points found on the skin that may have been caused by the splint. Don the hand splint so that the crease hits below the knuckles to get the 90 degrees of MCP flexion. Step 1. Lock. Lock the splint at the wrist. The Curlix is locked twice at the wrist in order to hold the splint into place. Step 2. Pull. Anchor the splint by pulling from between the thumb and digit 2 down to the base of the splint. The pull down to the base should be tight enough that it almost bends the splint, causing it to fit snugly on the hand. This should be done twice. Step 3. Cover. Cover the base of the splint up to the hand with the least amount of Curlix possible. It's important not to overlap the Curlix too much, as longer arms will require more, and you still need Curlix to seal the fingers. Step 4. Seal. Holding the fingers down, tightly seal the fingers and the thumb into place. Notice as the fingers are held into place, they are nearly at the end of the splint. This indicates it's a good hand splint from the OT, and it's fitting properly on the patient. Lock the Curlix into place with some tape. Remember to elevate. Once the splint is properly donned, elevate the upper extremity above the heart. Elevation helps to decrease swelling, so remember to elevate the arm above the heart, ramping distal to proximal. Common wear schedule. If indicated, the hand splint should be worn at all times. Up next, standard ankle splints. Here's what a standard ankle splint looks like. They're indicated for concerns of possible plantar flexure contracture with prolonged bed rest, to float the heels, burns to the knee, calf, and ankle, and burn or damage to the anterior tibialis muscle. This is the neutral foot position that a splint is desiring to achieve. Precautions include improper donning, any red marks from the splint, any ID bands or lines that may cause a sore with prolonged pressure. And an ankle splint is absolutely contraindicated if the patient already has a plantar flexure contracture greater than 15 degrees. Here's what a plantar flexure contracture looks like. Reminders: skin checks should be done every time the foot split is donned or doffed. A blanching sore is okay, but a non-blanching sore may indicate that the splint was not donned correctly and/or it should not be put back on. Nurse and therapy team should be in communication about the fit and any red marks that have been observed. The skin should be checked for any new red marks or skin breakdown, and any new changes should be communicated to the nurse. When placing the ankle split on, it is important to get the heel all the way down into the base. If the foot does not want to dorsiflex into the base of the splint, bending the knee may aid with dorsiflexion. Straps should be tight enough to hold, but loose enough that a finger can slide between the skin to prevent a sore. Here, straps are properly donned. Remember to elevate the lower extremity above the heart with pillows, ramping distally to proximal. A common wear schedule is 4 hours on, 2 hours off, which coordinates with the nurse's turn schedule. That is how you apply a foot and an ankle splint. Special thanks to my clinical instructors Joe and Allison, to my lovely actress Becca and cameraman Ryan,